Hello everyone, welcome back from some hopefully successful networking, and welcome to the Healthcare Showcase. The National Virtual Incubator is a pioneering new network supported by the UK government. The NVI connects using Cisco telepresence, incubation centres, research facilities, science parks and academic institutes. And by linking new research with new business innovation across the UK, the NVI aims to drive collaboration within a wider community. The NVI network is contributing to day one of the conference with this morning's session, the Healthcare Showcase, which will include inspirational case studies from Andrew Griffiths, the Chief Information Officer and Director of the NHS Wales Informatics Service. Both speakers will be sharing their insights and experiences of how they're enhancing the evolution of healthcare. This session is being streamed live from Cardiff and Birmingham across the UK via the Cisco National Virtual Incubator Network, or the Cisco National Virtual Incubator Network, the NVI. So I'd very much like to introduce Andrew Griffiths to the stage, and he can share some of the experiences he's had in this healthcare showcase. Thank you very much, Andrew.
Thank you very much. I'm looking at these glasses of water because I think that's mine. There's an important distinction. I've got a bit of a cold. Having a cold with me means my nose runs, my throat goes a bit croaky, and my mouth goes a bit dry. All the things that you get when you're a little bit nervous, speaking as well. So the double effect should be good for the talk. I think I've now broken the one rule which says never tell your audience that you're nervous. There's quite a big build-up to say all of our experiences that we've had in achieving and making changes in clinical information. Getting a clinical electronic information system is a huge task, and I think it's one that we've all underestimated at some point or other. So what I want to do this morning is just very briefly talk a little bit about our journey on getting to the electronic patient record, the single patient record, recognizing that the single patient record is really an amalgamation of a distributed set of information that exists about a patient or about an individual as they go through the healthcare system. One of the challenges is how do we turn the paper-based systems into something that's electronically available and overcome some of the issues that we heard about earlier on. How do we get interoperability into our record keeping within the health service? So we have got quite a clear aim really, which is to get this single patient record, something that is available wherever the patient turns up, whichever organisation they go to, and whichever care setting they're seen in. How do we make sure that the right information is provided to the clinicians who are looking after the patient? So I just want to talk a little bit about what some of the building blocks that we've put in place. And those building blocks that are on the screen here, I'm not going to talk about them in detail, but what I want to do this morning, just to give you a little flavour, is talk about something that we're calling the Welsh Care Record Service. Now, I wrote a few notes down from our last speaker, and I think the Welsh Care Record Service is a good example of a mashup interoperability system that will create a network effect, or at least that's what we want it to do. So the aim of the Welsh Care Record is to do that, and of course what we need is everybody's help in order to achieve that. And hopefully as we go through, you will get the gist of what we're seeking to achieve. My apologies to some of the Welsh folk in the audience who will be familiar with some of this, and perhaps have heard me say some of it before, so my apologies on that. So this slide really just shows us some of the progress that we've been making towards that single record. We've got a project which we've called the Welsh Clinical Portal, and that project enables information to be viewed by the clinician, accessible wherever they are, and it provides information around tests, test results and images. It allows people to make requests for pathology and radiology. And increasingly, we want those functions to increase. So there are more functionality available within the Welsh Clinical Portal. But it also gives an insight and a view on other information that is available. One of those sources of information is the individual health record. And the individual health record is essentially the primary care record, a copy of the GP record. And we've had that available for some years now in out-of-hours settings. And increasingly, we're making that now available through the Welsh Clinical Portal with the use of appropriate auditing tools to allow secondary care clinicians to view that record initially in emergency situations, but eventually into more planned care and scheduled care situations as well. And the individual health record has been a great success and will be a key part of that overall record that we're creating for the patient. Then we've had My Health Online, which is the patient space, the place where the patient can go and have a look for information. Now, at the moment, that is restricted to appointment booking in primary care and repeat prescriptions. But again, that is an area that we want to expand. And we see that, maybe the brand, if I can put it that way, as being the mechanism where people can come in and have a look at information that we put there so that they can see that information. It's an important part of what we're seeking to achieve. Then we've got a list there of a few of the departmental systems, and those systems that we have standardised across Wales in various ways, as well as on the bottom of the list there, the Master Patient Index, which is the authoritative view of the patient's details, their name, their address, those kind of details, but really highly important to make sure that we are identifying the right patient. And then the National Active Directory is a list of all staff and their details, and again allows us to authenticate people to have access to the records. And again, it's a really key part to what we're doing to make sure that the right people can see the right information. I put up a slide here, which is a slide that I'm sure has been used over the last 20 years. And probably when I first used this kind of slide, I thought it would be a year away when we would be seeing the demise of the medical record. But the demise of the medical record has been long talked about, long expected, but a long way in coming. And I think the electronic record has been treated really quite specially, a little bit like Dorian Gray, kept pretty, kept healthy, looking good, whilst in reality being meanly and self-centered and unhelpful. Only surviving, the electronic record, only surviving because in the dim recesses of our hospital somewhere is the ugly truth. The medical record. It's decaying, it's getting older, it's looking more decrepit, but meanwhile the clinical record goes around doing its thing without being untarnished by the realities of hospital life. And so I think our task is to make sure that we actually get rid of the medical record eventually, and that we make the clinical record, rather than just looking pretty and good and keeping it perfect in splendid isolation, but actually making it helpful and useful to clinicians in their daily practice. We know that the challenge of that, of course, is that the medical record, as we heard earlier on, is actually a really good tool for interoperability. There's a good standard. If you've got a piece of paper, you can put it in there. The barriers to interoperability are quite low. It means you write something down, you put a bit of information on it, you send it to medical records, and after about 6 weeks or so, if you're lucky, that might find its way into the note and never to be looked at again, but at least it's there in the note. And so in that sense, the ugly truth of the medical record is that it is difficult, but it is interoperable, which means that it's been popular and it has stayed around for so long. So the challenge for us in making the record electronic is that most records are still paper. Paper is good for interoperability, and therefore it is easy to use. People understand it, they know how to navigate around it. We've done a lot of work in Wales around scanning some records, and we know how difficult that can be and the challenges that gives. And some of the challenges are how do you then navigate the scanned image record? How do you find your way around it? The other challenge, of course, is that electronic records are distributed as well. And so we've got pockets of good practice. We've got different systems looking after different parts of the patient's care. How do we bring all of those things together? Well, one of the things that we've been examining and looking at is the sort of internet search technologies. I'll step through this slowly, but I'm sure this audience is well aware of this kind of thing. But certainly if you're looking for information, then you will use something like Google. We heard this morning that Google perhaps isn't the best example in health, but certainly they've got search sorted, at least I think they have. So you go to a search engine like Google, you know that your website content around the world has been searched and indexed, and then you make your search, and you set your search criteria, you get your search results, and then as a result of that, you select the page that you're looking for, and you go to that website, you collect the information, and then it's brought back for you to view. And so we are thinking about the same sort of techniques being used for the medical record. How do you get access to all those disparate bits of information that are kept electronically while you do the same thing? You create an authoritative place to go to, which suggestion is called the Welsh Care Record Service, which is an index and a pointer to the actual records. It's also possible that you might store some of those records, but that's a little bit of the detail, I guess. But we do the same thing. The documents, the records are indexed. And of course, we've got the opportunity, because we know those indexes, to be more rigorous about the metadata that we keep, about the kind of searches that we're expecting and that we want to see. And so we try and make sure that as best we can, but we don't want to make it a bar to put in information into the store, but as best we can, we make sure that those records are indexed well and successfully, which then means that in a clinical application like the Welsh Clinical Portal, the person is able to set their search criteria, get their search results, pick the information they're interested in, and then get that back from the record store and view it, as you can see there. So we're thinking that's a good technology in order to help us move forward into a world where we are replacing the medical record and not doing what we've traditionally done with it, which is kind of repackage it all the time in paper format. Now, here's a rather detailed slide, and I need to get my notes on this particular one because I can't quite read what all the boxes are saying there. But this is a little bit of our architecture for the single record. I'll rattle through it. And we have the various components. So on the left-hand side, your left-hand side, we have there the building blocks of what we've put in place. It's important to say that the journey over the last number of years has been a journey of putting the various fundamental building blocks in place. And then we now feel, having got those building blocks, that we're able to use those and develop new applications and ways of working that will help clinicians do their job and replace the medical record. So the first one there is something that I've already talked about, is the National Active Directory, a single place where we can authenticate who the users are, who are the people that are accessing the information. Then we come down from there, we've got the Master Patient Index, which is the place where we can identify the patient. It knows all of the identifiers that are in use in the NHS in Wales from those systems that are linked to it. And again, it's an important resource that we can access to build these applications and search for information. Then I've got on there the Welsh Care Record Service, which I want to talk a little bit more about in a moment. And then at the bottom there, we've got the National Reference Data Service. Now, that's an important part, again, of the architecture. It's a place where we've got all the important information referenced, so that there is one source of that reference information in order to make our searches more successful. So if we know, for example, that we've got all the GPs there and they're ordered in a particular way with particular codes, then we know that we can reliably search on those criteria, and the same with secondary care clinicians and other important information as well. So that's a resource that we're continually adding to. And then, so those are the boxes in green. At the top there, we've got the applications such as the Welsh Clinical Portal that actually interrogates those items there on the left and enables it to do a search through the Welsh Care Record Service. And then at the bottom, you've got there the multiple sources of patient information. And those are varied and wide-ranging, and we can keep adding to those. But what we're talking about in the Welsh Care Record Service is a way then of indexing that information so that we can bring that back successfully to the clinician. This next slide shows us a little bit more about the Welsh Care Record Service itself and shows the building blocks of it. And you'll see then in the green bit there, you've got the electronic forms or the e-forms generator. E-forms is, again, a major part of what we see the Welsh Care Record Service being able to provide. There's a couple of reasons for this, that we think this is a particularly good technology to use. It means that we can generate new forms and new content without recompiling applications. So we've always found ourselves in a situation where if we want to add new data sources, we've had to go to the supplier of a particular system, ask them to recode their application, and then make it a standard part of that application for users then to use, which can be disruptive to existing users who don't want that particular information, and also can take a long time to actually come to fruition. So we see the generation of forms with content that is developed by individuals as a really good way forward to expand the scope of what we're able to do and make sure that clinicians and end users are able to generate their own content for the record in much the same way as they can now with paper. They just sit down and they work out what they want to do. Now, of course, there's various challenges in doing that, and there are various things that we would want to put in place to try and make sure that that information is as useful as possible. So there will be standard elements that can be put onto the forms, possibly demographic information about the clinician, those kind of things. Perhaps standard ways of displaying the date, those kind of things that we can actually put in a library so that people can choose from. But if they find that there aren't things in the library, then they can generate that for themselves. And in a sense, if they want to create their own specific form, they can do that. But they realize then that the use of that by other people is possibly more limited. So eForms is a great tool, we think, for generating new content, for getting that network effect of getting people involved in generating their own working practice and their own ways of using information. There's been a lot of emphasis in the past, isn't there, on things like big data sets. Data sets are really difficult to actually put into systems and actually aren't very relevant to most clinicians' way of working. And what we need to do to engage people with collecting information is make it useful for them in their clinical practice, to help them, let's be honest, reshape their clinical practice to be more effective and efficient. Then on the middle bits there, you can see that we've got then the repositories that this Welsh Care Record Service is looking into. We have at the moment split that into two bits. The diagnostic tests, the results from radiology and pathology and from other sources as well, and then into a national document repository, the place where we can put various different kinds of documents, some which we already know about, outpatient letters, discharge, advice letters, things that are standardized, but also new forms of information that perhaps haven't been standardized. There's also an ability here for us to interoperate with other individual systems where perhaps someone has got their own clinical information system, and whereas at the moment what they do is they print off a summary of the care at the end of an episode and then send it on its way to the medical record. We don't see any reason why that person at the end of that care doesn't, in a sense, print it to the Welsh Care Record Service and store it then electronically, finding its way immediately into the record and then being accessible by other people who are caring for the patient. So again, we are lowering that bar to interoperability. We're saying if you can produce it in a form that can be picked up as a document, then we will take that in without wanting to know anything about the data or the standards of that data that is used on that form. So that's a little bit of I think, a little bit of an overview of how we see the Welsh Care Record Service. It's a store of documents which is searched and accessed by an index. And at the top there you can see the index, and I just want to say a little bit about that index. We're using a technology called Solar, which is an open source search platform. And you can see there's got an active community, and that's what we've been using for a little while as a trial to see how this works. It is a technology that is well established and well used, and if you've used any of those products on the screen there, Netflix or something like that, in searching, then these companies use Solar as their search engine, as their way of indexing all their records and making sure that they can access those records. So one of the things that we're able to do with Solar, we've been trialing it for a little while, is it does give us greater search technologies and search abilities. So one of the things that we're able to do is full text search. So you'll see there the little search box. And so we've now accessed the patient record. We're looking for a particular document, and we can start to type. And just in the way that we do on the web, you start to type the letters in. I'm having trouble clicking onto the next slides. And as we do that, the search gets refined automatically for you. And so Solar technology allows you to do this. We've got this working currently with about 4.5 million records that we've got in a trial, and it's working very well. And so as you do that, you start to refine the documents that are presented to the clinician. And you can see that being refined then down to one record. You can then, of course, click on that record, and that record will come up on the left-hand side. Again, my left and right mixed up. On the left-hand side there, showing the actual document that had been referenced. There's also other ways of searching, which is faceted navigation. So this is where you can see there, again on your left-hand side, is it? I'm getting completely confused on my left and right. You've got the little search criteria. So we can set up those facets that you want to search through. So this is a little bit like searching for your hotel room, where you say, I want a hotel with a restaurant or with a swimming pool or in the city centre or whatever it is. So you set up those key search criteria, and then you start to generate the numbers of records that are available. So you can start to pull in on the records that you want to see. Because one of the challenges is, how do you get through this morass of information? And in the traditional medical record, of course, in paper, then you've got various clues to that. You can search by looking at the different sections. In much of the way, we've got the faceted navigation. But also you've got those visual clues, those documents that you know what they look like. And so again, we've got the thumbnails there in the middle that start to give those visual clues to people of the documents that they might want to see. So all of those things come as a result of us using this solar cloud. For our installation of the Welsh Care Records Service, I won't go through all the detail of this, but this is how we are setting it up. So we've got it running over the 2 data centres. We've got various nodes and shards and load balancing. We've got full resilience on the system, and currently we've got the capacity to store around 250 to 300 million documents, but we know that that is scalable to well over in excess of 1 billion documents, and it is performant in doing that. So that's the technology that we're using to create this Welsh Care Records Service, and we're starting to index existing documents that we've got. But this year, we want to make a real push on this and start to build up this Welsh Care Records Service. And one of the key things about that is, how do we create the innovation? How do we get people to start developing documents? How do we create the right framework so that people are able to do that and if you like, create their own information needs? I got very quickly, I realise I'm running out of time, 3 little examples of this. One is the Discharge Medicine Review. This is an application that we've written recently. So as well as being able to create forms, what the building blocks now allow us to do is build applications rapidly, because we can use the various elements in the building blocks and use them and create a little process flow, if you like, so that we can build applications. So this example, the Discharge Medicine Review, was something that was designed, I think, at the back end of December, and it will be available for testing, end-user testing in March. So we're seeing a rapid development and deployment of information as a result of using these building blocks. And essentially what it's doing is it's creating a form, but it's giving a bit of a workflow to that form. So what's happening is that when a patient is discharged from hospital, they're given their discharge advice letter. The patient chooses that they want to send that to a particular pharmacy. That pharmacy then receives that document and gets an alert by an email that says there's something for you to look at. The pharmacist then goes in, has a look at that discharge advice letter that's come electronically from the hospital. They then do their discharge medicine review, which currently they do on paper, but now they've got access to the actual pharmaceutical information, so they can see that immediately. They can generate their discharge medicine review form, and then they can make their notes. And in studies, I think, of about 242 discharge reviews, I think they were found to be about well over 8 errors that were seen to be critical, patient safety critical errors that have been made on the medication. So it's a real key application. So the pharmacist goes in, they pick up the discharge advice letter, they create the discharge medicine review, and they're then able to phone the GP if there are any patient safety issues with that. And then we see that form then going back and being part of the Welsh Care Records Service. So that's just an example of how we've been able to use forms in a more specific way to develop an application that has a workflow process around it and gets an idea from conception into reality in less than 6 months. The other thing that we've been looking at is sharing information with the patient, because again, this is a form of technology that allows us to do something quite smart. We can start to bring documents, and you can see at the bottom there, just the ability, we haven't developed this at the moment, but the ability for the clinician to click to say, I'd like the patient to see that as well. And when they do that, that then creates the metadata around that form that says, this is available for the patient's record as well. We have got a lot of work to do then to look at where do we create that repository, how do we make sure that the patient search engine then can see this information. But it's a building block that we can use, and we think we can develop applications quickly. There's a little schematic of that, but I haven't got time to go through that. And the final example is really the community care information system, where we're looking at sharing information with local authorities, where we're trying to make sure that the clinicians on the ground have got access to the same information. And again, we can make sure that documents here used in community and social care can also be accessed by the Welsh Care Record Service, so that in the search, those key bits of information can be accessed by the clinician viewing that single patient record. So, in very quick summary, I think the Welsh Care Record Service is an exciting opportunity for us to take the record out from paper, make it electronic without doing away with all of the advantages of interoperability that exist with the paper record. It is also an exciting opportunity to make sure that loads of people are involved in developing content, and that we're not recompiling applications every time we get new content. And so I think the challenge for us is, how do we make sure that this works? How do we make sure that everybody owns it, that everybody sees it as part of the solution to making sure that information is available about the patient, where the patient turns up in our systems, creating new ways of searching information and making sure that patient care improves as a result of the technology that we are deploying. Thank you.
I think what we're probably going to do now is switch over to, do we have time? It's 11:30. Yeah? Yeah?
Yep.
Okay. So,
You've come straight through to Birmingham.
hello, Robert.
Yep, he's here next to me.
Okay, well, I'm going to
Thank
hand,
you, Andrew. You're welcome.
I'll hand over
Thank
to
you
you
very
now,
much.
so there's no more of this laggy stuff. Thank you.
Thank you. Welcome to Innovation Birmingham. My name's Hugo Russell, Project Manager here at the Science Park. My pleasure to introduce Andrew. I've known him for a number of years, particularly from having had my own medical devices. Andrew's been involved in commercialising and helping people take medical devices and solutions to NHS problems for years. So I'll hand over to Andrew, and just give me a second while I zoom in and also set up this presentation. Over to you, Andrew. Sorry, Rob.
It's Rob.
Sorry, man, I'm off another world.
No worries. Just cue the presentation. Hopefully everybody can hear okay and see my slides. But I think what I'm just going to do is build on the previous presentation, really, to talk about probably stepping a little bit further back in terms of the digital health side. I talk about the challenges that the NHS faces in particular, and actually why I think now it's becoming an environment which is more conducive to the uptake of some of these technologies. So I'm going to really talk about the innovation team to start with, and then move into some of the kind of challenges the NHS is facing, and then move to some of the technological solutions, probably more, perhaps sit more in the patient's hands, and then kind of expand on some of the barriers and challenges that those technologies face, and how we are aiming to support those technologies to move forwards. So I'm going to try and advance the presentation. There we go, it's working. So just a very quick update. I work for NHS England in the innovation team, and we've set up a couple of initiatives that support the uptake of innovation, spread of innovation across the NHS, primarily in England. And we have something called Innovation Connect. And really, in a nutshell, that's a service where we can identify clinical expertise within our networks at a very senior level to support the development of any innovation, and that might be as diverse as a medical device, through to a new pathway, a new way of working, right the way through to medicines. We tend to see more digital technologies and medical technologies that come through our team and the medicines end tends to deal more with where the uptake of medicines isn't happening at the right pace. So we basically provide a support mechanism for that, and we work with a landscape here which is quite large in terms of academic health science networks, industry bodies, to try and bring the right people around that individual solution to provide that level of support. And a couple of conversations we had prior here with companies developing in this space is actually how do you get to the right individual quickly to identify if the solution that you've got is actually meeting a defined clinical need. And I think in the digital health space, that kind of support is quite key. So we're talking more about the technologies that go around the patient record, and that perhaps sit more in the patient hands than the systems at the back. Just a couple of examples again from that for our team, in terms of how we managed to advance some innovations quite quickly into practice in the NHS. I won't show you any gory pictures of the episiotomy product at the top there, but this is a product developed by a clinician, and we've been able to kind of fast track it through the NHS, get it into use by providing an element of some prime funding, and now it's part of standard practice within the obs and gynae community. So it's moving quite quickly, and there's technologies around diagnostics as well, which you'll see there. Again, it's about spreading the expertise from one location to another across the patch, and some telehealth as well, which I'll touch on a little bit more shortly, where we've actually funded a specific service in haemophilia, looking at a very particular condition, but helping to manage and reduce the contact and unnecessary appointments to hospital using that technology. And very quickly, we have a portal as well, which I'll just skip over now, but it's really a kind of an area for sharing best practice and innovations, and also engaging with us as well in terms of our team, in terms of those solutions. So, which we'll share the link afterwards. I think just probably touching on the societal challenges. I mean, and this goes across health and social care. We're probably familiar with these kind of diagrams here, where we're starting to see obviously the growth of the older population, and it's really hitting now. And I think a lot of the conversations within NHS England are really around the challenges that it now faces. You can sort of see the challenges in terms of A&E currently, and a lot of that is to do with increased demand. The NHS is really good at caring for people. Social care is really good at supporting people. We're extending life, but obviously that the NHS then kind of has to change to meet those demands. So we sort of see that growing older population and shrinking younger population starting to really impact now. The diagram on the left is about, obviously, it's quite old, so we're kind of halfway up that diagram now. So just in a nutshell, and this is what I use in particularly a lot of conversations with industry to characterise that. We know the older population is set to double in that time frame. The 65 plus, the 85 plus, interestingly, population will quadruple in that time. And what we have in that area there is individuals living longer with long-term conditions that obviously require a lot more care and support. We also have a kind of perfect storm in, obviously, we have fewer carers as well. And I think it was last year where the number of people aged over 65 was greater than the number of people under 16, combined with the challenges of having kind of less money in the system. And by 2020, an estimated £30 billion funding gap. That equals increased and unsustainable pressure on the NHS and of course social care as well. And this is, I think, where digital technologies really can help and support that moving forwards. So just to kind of characterise this is some general figures around population change, which I think is quite interesting, and across the UK. Essentially, it's approximately a quarter of to a third of the population by 2033 will be in that age bracket. But you've got some really interesting areas where it's much higher than that. It's over it's kind of, it's potentially reaching half or more than half, in certain counties. Combine that with a bit of a deep dive into things like long-term conditions as well. And I've included hypertension on there as well, which is often not kind of included on the big list of top long-term conditions. But hypertension then potentially leads to stroke and coronary heart disease. It's an indicator of many different things, but managing and monitoring that is something that can be done by patients in consultation with their GP. And of course, as we see the older population grow, then obviously we see more prevalence of conditions like dementia as well, and stroke. All of these conditions here begin to grow. So the support really needs to be there to do that. And I'll just very quickly talk about the kind of old age support ratio, which I mentioned earlier. And this is sort of zooming in on a particular county, but again, looking at how the younger population, the working population, is often starting to be reduced in comparison to the over 65s, and places like Northamptonshire, where it's well over half of the population, it creates different challenges for different locations around the UK. And this is quite interesting. I've pinched this slide from the Young Foundation, which I think quite interestingly characterises health and social care, and in particular the contact points that happen, and actually I think where digital technologies can really really start to help and support. And this is talking about the journey from retirement, really through to end of life. And the orange blobs indicate, I'll zoom in there, they indicate the contacts with health and social care services along that line. And as you can see, it's fairly quiet to start with, but as you start to move towards the latter point of time, towards 75 plus, there's this kind of chaotic cluster of activity where you've got patients going into hospital with exacerbations of their conditions, maybe multiple conditions. You've got interfaces with social care, and you've got benefits. You've got a whole raft of things that start to happen there. And there's, I think, a place for digital technologies to try and smooth out some of that. That's kind of that process towards the end. And I think some of that is in the, I suppose, in the hands of patients and service users. And some of that relates to how health and social care is ultimately delivered. But the idea we can try and smooth that out, I think, is really where we improve patient outcomes and make significant efficiency savings to the system. I'm probably going to sort of step back into some work we did here in the West Midlands in Birmingham around trying to characterise some of the technologies that are probably more patient-focused, that enable the kind of digital health and the delivery of healthcare to happen more in the home and the community. And we did a project here which looked at fitting out an end of terrace Victorian house in a part of Birmingham, which really had particular needs in terms of housing, and obviously housing people with older people with disabilities. And we looked at how the built environment and the kind of layers of technology and support could actually enable much longer living in the home environment. So this was a kind of technology demonstrator at the time. But I suppose involved inside of that, I think, and I think not necessarily talking about how we deal with the data and manage the kind of patient informatics side. I've tried to sort of map the technological solutions against almost like a Kaiser pyramid, where you have, I think quite interesting for me. So you've got things like products at the bottom and solutions at the bottom that are around fitness and well-being. So products and devices that help somebody manage their own healthcare. And there's a blend between fitness, I think, and well-being and monitoring health and all those sorts of things, which is really growing as a marketplace. And the awareness of those technologies is certainly expanding. So that's a space where I think a lot of people are currently, and I think there's not such a huge jump in terms of patients taking some of those tools and using them to manage their health. And then you sort of move, as you move up the pyramid, obviously you get technological layers that many are digital technologies, which start to provide more support in the home and community as the need changes. So with dementia and early onset dementia, products around memory prompting and medication compliance start to fit. You've got then telecare and telehealth starting to fit in higher up. And essentially, as you raise the bar there, the technologies get more complicated. Kind of to the red line where it's sort of flipping over into, starting to get home care or actually potentially moving into some form of residential care. But I think the technology bit, for in many respects, in the hands of patients, sits underneath the kind of red line. I think the challenge for us is that red line is moving higher up in terms of funding. And there's an interesting element around how we can work with GPs and with patients to make some of these technologies perhaps more widely accepted and more available. And of course, we've got some information again around telecare and telehealth around the whole system demonstrator, which I think completed in 2012, which looked particularly at telecare and telehealth, and some of its outputs have been kind of argued in terms of data collection because it was a randomized controlled trial, but there are indications there that it was reducing the death rate in the individuals that were studied in that trial by 45%. The reduction in A&E visits by 15%, and kind of unplanned admissions by 20%. And this is the sort of thing we need to start moving towards, I think, to move away from that £30 billion deficit, which is kind of the challenge that we face at the moment. So just very quickly, just to focus in on some of the technology solutions that we're seeing more in terms of the innovation team. We've got things like Apple and its HealthKit technology, which is really Apple being an enabler in this space to work with developers to create products and solutions that link with Apple products, but again raise the awareness of individuals' health. So there's a whole series of records, a series of data that can be recorded on there that focus primarily on health. And their interest isn't so much in accessing and getting that data into the patient record, which I think is ultimately one opportunity. And I think there's a whole conversation happening there. Their interest is raising the awareness amongst patients and the public about their own health monitoring, their own management, kind of building on the health and fitness apps we were talking about earlier. And NHS England's response has been partly to create something called the Health Apps Library, which is the screen grab on the right, which is taking a selection of apps, mostly patient-centered ones. So they're apps that patients can use to manage their own condition. And they've been put through a process of analysis and kind of effectively checking that checking their efficacy and safety in this space, and creating a bunch of those apps that sit there. And there's a process there that developers, software developers in the space can actually engage with to make sure that there's a level of compliance. And there's a whole load of work going on in that space as well, which I'll touch on as well. But that's there, and it's part of NHS Choices as well for patients to access, and they're all free to use apps, I think, largely on that site. But we certainly see growth in that space in terms of the innovation team and actually in the regulation and actually which solutions are working best. It's quite difficult to work through some of that, but I'll touch on that a bit later on. As I mentioned before, when we talked about the house technology demonstrator we did, it was about 5 years ago now. The things like telecare products have been around for 25, 30 years, where they're alarming devices that effectively provide that community support and those alarms. But I think the growth and development of mobile technologies now has actually started to kind of create a new kind of era for these technologies, where they're less proprietary and there are more solutions out there which are better connected potentially. So you've got obviously better improvements in design and how these things work and look, but you've got things coming onto the market as such. For example, here this is Proteus, the mobile phone meds compliance product. So you've got your traditional medicines boxes here which will alert the patient to their medications. But this is a kind of next step, and it's looking at actually whether the patient has taken the medication, and it's using ingestible chips to do that within the medicines. Now that we've supported this through the innovation team, and it's actually being primarily used currently in clinical trials for gathering clinical trial data, but it's now actually starting to get into use in some clinical settings, and that's really being able to look at medication compliance and making sure the patient is taking the medicines and the right medicines and the right dosage. And what this is effectively is a device which reads the fact that it's a wearable patch that the patient wears, and it can read the fact that the tablet's being ingested, and it beams that data to a mobile device for putting out in terms of clinical review. You've got telehealth products as well, and again, they tended to be more proprietary boxes and systems. They're now, because of the development of the mobile technologies in particular, they're moving towards smartphones and being more ubiquitous in terms of their availability. So there's a convergence there that's happening in the mobile sector, and there's been quite a lot of work around pushing data from telehealth devices into GP records, and with the likes of EMIS in particular have been key to that, and I think Philips and EMIS as well have worked in that space. And I think there's a really requirement for more of that to happen. The challenge, I think, is what data is useful, and being able to filter the data that's not really going to tell you anything from that equation, but being able to drop the data and use it effectively. So the distance between the time in which the patient's with the GP and the time in between, there's meaningful information being gathered to help with their care. And there's loads of examples of pilot programs active across the UK in telehealth in particular. But it's really now looking to take on a much bigger part of the process. And then probably less obvious to people in terms of digital technologies, you've got a quite interesting convergence of technologies that do home automation, and again, using smartphone apps to control lighting and heating becomes quite key where for people who start having mobility problems, being able to control their home environment from their smartphone becomes more and more relevant. And some of these technologies, for example, the Lightwave product on the left here, came out of home automation systems designed for people with disabilities. So the thinking came from there, and this is now in the marketplace. And I suppose jokingly, it's sort of it's for the lazy man who can't be too bothered to get out of his armchair to turn the light off. But you've got things like Hive as well, which is probably more of the more widely commercially available solutions that do remote control of heating, for example. And if you can do that, you can help monitor and support an older or disabled individual or family member using these technologies. I think that's another area of development moving forward. So I'm just mindful of time here. So I think probably to touch on this and bringing in some of the experience that I've had in perhaps the past 6 to 10 years working in this space, is that and when we did the technology demonstrator here in the West Midlands, there's an awful lot of keen interest in innovation in the digital space. And I think the government has put a lot of money forward to encourage and grow those companies to do that. But I think we've had there's an interesting challenge that digital technologies face, a number of them, which I think we kind of define as the stumbling blocks. And where we see this really, I suppose with any innovation, if it requires a significant change to service delivery, so if it replaces a service or it reduces the requirement for a particular service, it can take an awful long time for that to bed in. So if you look at the challenge, because actually there was no mechanism to pay the GP for that, because they were paid on a face-to-face consultation. So where changes to service are required, then that can be a really significant process for slowing it down. There's a huge debate around data and security as well, which I think are now beginning to mature now. As you can see with the Welsh systems there, that's starting to really come together by bringing systems together and solving some of those security issues. That gets more complicated, I think, by the ability to share records, perhaps more with the patient. That starts to create some interesting areas. And I think payment systems, reimbursement and tariff as well around digital technologies, again, actually goes back to the change in the service delivery. Actually, who gets paid? What impact does that technology have on the system? And our savings, as we see quite commonly with things like telecare, social care, make the savings, but it's the NHS that tend to pay for those solutions. So understanding that process is key to driving and moving the incentive forward. And I think we're looking at in the past 18 months of being in the innovation team, again, a lot of encouragement to develop digital solutions, but it's created a market where there's many flowers blooming. There's lots of solutions. There's limited regulation, and the evidence base is really, really often really difficult to pin down. We know that these technologies can deliver significant benefits, but getting the evidence base in place and making that compelling business case has often been the challenge. But I think moving forward now, I think sort of really to kind of finalise here, the environment has changed. We do, I think, in the previous conversations around something in the past sort of 5 or 6 years, the NHS has been funded well enough to be able to cope. I think we're now in a point where that's changed, and with a £30 billion funding gap, the NHS has to make those efficiencies, and those efficiencies will come in terms of improving the way the NHS works and the way it engages with patients and reducing unnecessary contact. And it's become an issue, I think, really now where it's widened and it's opened the eyes really of commissioners in particular in the NHS to how digital technologies can help. And I would recommend that people read the 5-year forward view, which was published by Simon Stevens last year, the new chief exec of NHS England. And in there, it's probably not what I can really say, but there's a lot of talk around looking at digital technologies in a system-wide view. So trying to support the implementation of not individual technologies or approaches, but actually how these things plug in together. So multi-kind of modal systems. And there's some thinking around actually how we can make that happen across a CCG or across individual trusts, rather than, perhaps parts of those organisations. And I would watch out for comms around that happening, and in particular look at the forward view for some of that sort of overlay. The other side to it, and I think finally, really, on the app side and the health app side in particular, NHS England is working with NICE and the Health and Social Care Information Centre on providing some really good steer, in particular to developers around the regulatory steps that need to go through. So MHRA, for example, looking at devices when they become a medical device, if they're digital technology, and HSCIC looking at the connectivity between the data on that side. And there was a recent announcement by Tim Kelsey, who's kind of leading on the technology side to NHS England around a kind of kite mark for apps as well, and which gives a really kind of clear steer to industry. But that's my whistle-stop tour of the challenges faced by digital technology. Thank you very much.
Thank you very much, Rob. Good wrap up on that, and particularly on the size of the market. We'll just ask a question from people at this end here. Has anyone got any burning questions, particularly on the app side? Mary.
Hi there, I'm Mary Matthews. My company is called Memrica, and I'm developing a mobile memory aid for people in the early stages of dementia. It was great to hear that overview. Thank you very much for the insight, and it's great to see that very forward-looking view. One of the tensions, I think, though, that still exists between industry, particularly micro SMEs, and the NHS and the health ecosystem as a whole, is that technology startups like myself want to be very agile. We want to be able to test solutions quickly, and we want to be able to know whether this is going to be a valid solution or not. Engaging with the NHS to try and test that rapidly is quite difficult because you quickly come up against governance issues. Quite rightly, I mean, absolutely, none of us want to impinge on patient safety or confidentiality. But I think there is a tension between how you get to a solution rapidly and how you also respect the processes within the NHS. I'd be really delighted to hear your views.
In one minute. I think the way we do it is through our kind of Innovation Connect approach is that, work with us and we can try and steer through some of that. So we've got, there's a growing network for innovation and adoption spread in terms of academic health science networks, regionally based, that have a focus in certain clinical focus. But be it, working with us really to find the right clinical input to it first off and identify clinical champions. That's what we're developing and growing as a system. So you can quite quickly get the view, actually, this isn't going to work.
But I already have the view that this is very
exactly, yeah. I mean, which is where you grow. It goes from there. So, and it's an interesting journey from there, but sometimes it's quite complicated. So it's how we can then perhaps build in some funding or support to get that moving on quickly.
I'm going to have to gate crash you and hand back to Cardiff. Well, Andrew, we're going to pass back to you. Thank you very much, Rob, for your time on that. And may the conference go well. And thanks for allowing us to join in from here in Birmingham. All yours.
Well, thank you very much for that. So I think we've got some time to do some questions in the room here now with Andrew. Before I open it up to the floor, I'd like to ask you what you're excited about. A lot of the presentation you gave us is around enabling further innovations. So, if you and I were down the pub right now, what would you be excited about over the next 3 or 4 years happening now that we can get our hands on some of these connected data sets?
Yeah. I'm not sure I'd be that excited about it in the pub afterwards, but I think the big challenge for us is how do we, as I explained, replace the medical record, and how do we get information into routine clinical practice? And I think that's the big challenge for us, because we all know that there's a lot of clinical practice and ways of working in the health service that haven't changed for many a year. And some of that goes because they don't have the information to be able to do it, because we don't give clinicians the freedom to work in different ways. And I think some of the technologies we've now got will free that up and allow people to think differently about the way they work, where they have their clinic, whether they need to bring people into the hospital to see them, whether they can do it in different ways. How do they then record that and make sure that that is part of that clinical record? So I think we're finding ways of making it possible to allow that kind of clinical innovation. And so I think the exciting possibility, but it only comes about if people are engaged with it and know how to do it, is if we can get people in the health service to think differently about how do they record the care and what does that now enable them to do differently in the way that they work. So I think, I think one of the big areas is outpatients. I think outpatients is a huge drain on the NHS, just in organising it, making sure we get the clinical records to that place, making sure we get the patients there, that they can park their cars. And we know for most patients, a lot of the troubles is getting to the hospital. So I think we've got ways of actually changing the patterns of care in such a way that we don't need to do some of those things that we've always done. So I think that's quite exciting.
It sounds like quite a hard thing to do. Obviously, the process impact of some of this information is massive, and I guess that's the challenge going forward once we actually get the data. Yeah. Are there any questions from the floor for Andrew?
My name's Simon Emery. I'm a gynecologist, so a clinician. And I think there are loads of clinicians who would love to be able to use your e-forms and have a way of sidestepping the medical record. So have you got some really simple apps that we can actually begin to say, well, this is what we'll begin to populate, and I'll collect my data in the clinic, and I'll stick it into the portal, and I may be right in the case note as well. I think there's hunger out there, and what we need you is to facilitate that gap. And I'm not sure I heard from you how we're going to do it.
Yeah. You're absolutely right. You didn't hear that from me. But I agree with you totally. I think that what we've currently got is we've got a lot of the technology in place. We've got those fundamental building blocks which have taken, quite some time to get in place to allow this to happen. We've got the search technologies which we've started to pilot to see how is it scalable, does it work? We've got a couple of pilot projects that we're about to embark on for some new information flows, particularly around the nursing record, around cardiology and a few others as well. But part of what we want to do through those pilots is to look at how do we create that framework, as you suggested, which allows people then to take that off and innovate themselves and create their own forms. I think app development, to use the buzzwords, is a great potential mechanism of delivering some of that. And I think, one of the things that occurred to me as we were going through this morning really was could we in our pilots look at a way where we are giving a tool set to people to develop their own app that said, you can generate your own form and find some way of identifying the patient with that app, which I think is one of the difficulties. And if we can overcome some of those things, then we can allow people to develop in a little app space their own form that they append to the notes. So I'd agree with you. Our desire is to do that, and I think through the pilots we'll have a look at what mechanisms can we create to allow that kind of innovation to bloom.
Here's one at the back.
Hello, my name is Akil Benjamin. I'm from a healthcare technology startup. So what we do is we facilitate healthcare professionals like you to have electronic health records and have patient practice management tools, and even we have a telehealth solution. But the thing that really bothered me about your talk was the open source architecture was amazing to see what you were developing. But if you have is it going to be closed off? Will people only have to use one system? Because if you have no API or any integratable tool, that really reduces the adoption you'll have from your platform. And so what I'm asking is it in the architecture, is it in your forward planning to think about how you're going to allow integration from other people like me who would happily want to work with you in that sort of space? Yeah. That's the first question. Can you hold another one, or should I do one at a time?
One at a time is as much as my memory can cope with. I didn't talk about the API side of things, but clearly in order to do what we've done, we have created APIs to do that. Those APIs are open, and I think we've got a way to go to looking at how we publish those and make those available to other people. But that's certainly something that we intend to do. So a lot of those components that you've seen there, we have written up some of those into a kind of a toolkit for, we called it integration, but perhaps we should call it interoperability. So that does exist. I think there is a challenge for us about how do we make that available to other people, and how do we create a marketplace and a way of getting startups and other people to actually integrate with the health service. I think that is a challenging area, not least because of the procurement issues that are raised as a result of that. But I think there is room, there is certainly a space there for that to happen. And certainly the way that we've developed those key components of the architecture has been with that in mind, not least for ourselves to be able to do things more quickly. And I think in the discharge medicine review, what I was aiming to show was that as a result of those standard interfaces, we have been able to develop and deploy applications far more quickly. We'd like to make that available to a wider audience. How we do some of that with some of the procurement challenges, I'm not entirely sure, to be truthful.
Can I have another one?
Can we come back to you if we've got time? So there's definitely another one down here. Thanks.
Thanks, Dave Harvey, Medical Connections, radiologist and IT person. A quick follow-on from that point. I wasn't going to raise the question, but as it was so linked to the previous answer you've given. Brilliant to hear that you're going to be having APIs that people connect to. But how much of a market are you going to have if that's a Welsh-only API? And should that, if you're going to be playing in the rest of the world, be based on standard APIs, which will then give far bigger impetus, not only for people who can connect to you, but for people who connect to you, then to be able to sell to the rest of the world?
Well, I think the answer's probably self-evident. But I don't think it's our place necessarily, don't get me wrong when I say this, our place is not to create a market. Our desire is to create solutions that work for the health service. Now, I do accept the point that having a vibrant market can really help us to move that forward more quickly. So I'm not against creating the market, but that hasn't been our major driver. What I think we are keen to do, though, is we are keen to work with any standards that do exist already, and you'll be familiar with the ones that exist around radiology, and we've tried to make sure that we've linked in with those so that there are wider tools and there are wider technologies. So, for example, in the image sharing project that we've got, and I think you're familiar with that project, we are using internationally recognised tools and ways of extracting data, and we want to continue that so that when we come to procure new tools for that, we've got a big marketplace who are able to compete for that work. So I'm certainly not. I'm very keen that we do as much as we can to make sure that the market that we go to fish in is as wide as possible, and we've got an eye on that. But at the same time, we're also keen that we develop innovation internally in the NHS as well, particularly around the forms generation.
Hi, Nina Cross from West of England AHSN. Just a quick question about data quality. You're inviting people to create e-forms, to push information. How are you managing data quality, and what's your vision for the future for things like decision support?
Data quality is clearly a key issue for us already in what we do. And we do quite a lot of work on the sort of data integrity and making sure that the data is of particular quality. I think I'd agree with the earlier speaker who mentioned the fact that one way of improving data quality is by people using the data. And I think one of the biggest problems we've had with electronic information is that people haven't used it in their clinical practice. And so then when we come to secondary uses, we find the data is lacking. And it's always been a slight puzzle to me that we're always concerned about the secondary care use data quality and we're not concerned about the primary use data quality, but actually it has more of an impact. Which probably tells you that it isn't used as much or relied upon in the primary usage. So I think our intention is to really drive up the primary usage of the data, which we believe will have a positive impact on the data quality because more people are invested in making sure that that's right, and there are more reasons for making sure that that's right. And hopefully that will help all those other things you said, I can't remember what you said, the decision support tools and techniques to do that, and some of the things we heard on earlier on about, you looked up this, why don't you think of this, or those kind of tools. So
I think we may have time to go back for the follow-up, and then...
Sorry, last question. You've developed something that rephrase. How do you control the end user? That's the question. Because how do you control access to who can get access? Do I really want a doctor I've never met from a far-flung land just being able to search me up just like that because he can? Or it's a real thing? How are you going to control that?
Clearly access control is a key part. And again, that's why as part of those building blocks in our architecture has been patient identity is clearly very key in pulling any record together, but secondly is the authentication of the end user who is able to view that information. We've got some really quite tight rules around that, and the approach that we've taken is that every clinician, everybody who will have access to the record should have a legitimate reason for accessing it. Now there's been various pilots around how do you create and show that legitimate access. The approach that we are taking at the present time is we've just installed a tool for intelligent auditing of the access of records. So essentially, when a record is accessed, it creates an audit of who accessed it and when. We are then able to use this tool to look through those audit logs and see who has viewed the record. We're then able to intelligently look through that information and determine whether those people had a legitimate reason for accessing that record. So we're really seeing it as a professional issue, that every person who works in the NHS has a professional duty of care and if they fail in that by looking at records that they shouldn't be looking at, then it is a professional standards issue for them. But we are actively looking through those audit logs, making some of those links and trying to make sure that we're making, seeing, was the patient in that hospital when you looked up their record? Was there an episode of care going on? Do you live in the same address as the person the record you've just looked up? Are you a person who's been trawling lots of records for no particular reason? So there's all of those searches can be done on the intelligent audit tool to make sure that we are, in a sense, policing the access of that record. But it is a difficult conundrum.
Okay, so I think that's it from the questions on the floor. I've just got one final question. So obviously we've got you and we've got Robert, the innovation lead in Birmingham as well. So there's lots of people here who've got some fabulous ideas for improving healthcare services. What's the best way of getting some time with or getting our ideas to the top of the tree to you guys?
Well, I think that's always a challenge. I think today and this conference is part of that, isn't it? So I'll be around in the conference, other people are around in the conference. I'd be very happy to talk to people and understand the particular challenges and any of the ideas. I think that's probably the best way.
Sure.
I'm doing it.
Okay. Well, thank you very much. Thanks very much to everyone in Birmingham. And we'll break now and see you back in about an hour's time. Thank you very much.